Optical diagnosis of colorectal neoplasia. My objective in this presentation is to present to you the current evidence of how to make a real-time diagnosis of the histopathological type of the neoplastic lesion during colonoscopy. The presentation is going to start by introduction about the Vienna histopathological classification of colorectal neoplasia, then, how to diagnose the histopathological type endoscopically or optically. And finally, the conclusion. First, the Vienna histopathological classification of the GI neoplastic lesion. It classifies the neoplastic lesions into 5 categories according to cell atypia and the invasion depth. The important information here is definition of cancer in different GI parts. Esophageal or gastric cancer is defined by lamina propria invasion, but colonic cancer is defined by deep submucosal invasion. And why is that? Because the lymphatic vessels in colonic wall are found only at the level of deep submucosa. Therefore, invasion down to less than 1000 micrometer in the submucosa is associated with very little risk of lymph node metastasis and could be cured just by complete endoscopic resection. The aim of optical diagnosis is to take real-time treatment decision, and therefore our optical diagnosis classification should be based upon the available options, which are follow-up, piecemeal endoscopic resection, en bloc endoscopic resection and surgical resection. Therefore, our optical diagnosis classification includes 4 classes, each one corresponds to one treatment option. Class 1, that could be followed up without resection and includes the hyperplastic polyp. Class 2, that could be resected in piecemeal and includes the low-grade adenoma. Class 3, that should be resected and blocked to enable pathological assessment of lesion margin and base for invasion status. And it includes high-grade adenoma and superficially invasive lesions. And finally Class 4, that should be resected surgically and includes deeply invasive carcinoma. These days, treatment decision is no more based on the forceps biopsy, because it can assess only the cell atypia but cannot assess the depth of invasion, which is essential to know the histopathological type of the neoplastic lesion. Now, how to optically diagnose the histopathological type of the lesion in order to make a treatment decision? The answer is by using a number validated classifications and signs. We are going to start with pit pattern and the vascular pattern classifications as they form the basis of the other classifications. Let me first explain what are the pit pattern and the vascular pattern. In colonic mucosal image we are going to see 3 colors, dark color which represents the crypt openings, and actually it is very hard be seen without magnification except in type 2 open pit pattern characteristic of sessile serrated adenoma. Then there is the white color which represents the apical view of marginal crypt epithelium. And finally there is the red color which represents the lamina propria capillaries underneath a single layer of epithelium. For example, this lesion shows branched white marginal epithelium that correspond to Kudo type 4 pit pattern and red meshed uniform capillary vessels surrounding the pits of the crypts that corresponds to Sano type 2 vascular pattern. Kudo found that the surface pit pattern is correlated with the pathological diagnosis of the neoplastic lesion. Therefore, he used the magnifying endoscopy plus the conventional chromoendoscopy to classify the pit pattern into 5 main types, and validated the association between each type and specific pathological diagnosis. Type 1 pit pattern has round uniform pits and associated with normal or inflammatory mucosa. Type 2 pit pattern has serrated or star-like pits and associated with hyperplastic polyp. Type 2 open pit pattern has opened with mucin-producing pits and associated with sessile serrated adenoma. Type 3L or large pit pattern has large tubular pits and associated with low-grade tubular adenoma, that is often polypoidal. Type 3S or small pit pattern has a tiny tubular or rounded pits and associated with high-grade adenoma, superficially invasive lesion or even deeply invasive carcinoma, and often seen in depressed lesions. Type 4 pit pattern has regular or homogeneous sulcus, branched or gyrus-like pits and associated with low-grade villous adenoma that is often polypoidal. And then we have type 5, which is divided into 3 subtypes. Type 5I, low grade or 5 irregular low grade, that has an irregular pits, in an area that shows smooth transition to other regular pit patterns at its margin and is associated with low grade or high grade adenoma, or superficially invasive lesions. Type 5I, high grade, has an irregular narrow pits, in an area with rough or demarcated margins like depression, large nodule, or reddened area and is associated with deeply invasive carcinoma. And finally type 5N, or non-structural pit pattern, that has lost or broken down pit pattern structure and is associated also with deeply invasive cancer. It was found that the diagnostic performance of Kudo's classification is satisfactory with a pooled sensitivity of 89% and a pooled specificity of 85.7%. Now, the vascular pattern or Sano's classification. Sano also found that the vascular pattern is correlated with the pathological diagnosis of neoplastic colorectal lesion. He used the magnifying endoscopy plus virtual chromoendoscopy with narrowband imaging or NBI to classify the vascular patterns into 4 main types, and validated the association between each type and specific pathological diagnosis. Type 1 has no or hardly seen meshed capillary vessels and is associated with the hyperplastic polyp class. Type 2 has visible uniform meshed capillary vessels surrounding the pits and is associated with low-grade adenoma class. Type 3A has a highly dense, irregular and branched with blind ends capillary vessels, and is associated with high-grade adenoma, or superficially invasive lesion class. And finally type 3B, that is nearly avascular or has just loose microcapillary vessels, and is associated with deeply invasive carcinoma. The overall diagnostic performance of Sano's classification is satisfactory. However, the performance is weakest when differentiating type 3A, type 3B. Now to the famous J-net classification. In 2014, the Japan NBI expert team or J-net classified colorectal neoplasia by using magnifying endoscopy and NBI. The classification includes 4 types: type 1, 2A, 2B and 3. Type 1 has hardly visible vessels, and has surface pattern in the form of regular dark or white spots, which correspond to the type 2 rounded crypt opening or its marginal epithelium, and is associated with hyperplastic polyp that could be followed up, or sessile serrated adenoma that should be resected. Type 2A has regular vessels surrounding the pits, and the surface pattern shows regular tubular or branched white lines, that correspond to the regular pit pattern types 3 and 4, and is associated with low-grade adenoma that could be resected piecemeal endoscopically. Type 2B has a highly dense, non-uniform, irregular, branching vessels with blind ends, and irregular or obscure white lines that correspond to type 5I pit pattern, and is associated with high-grade adenoma or superficially invasive lesion, that should be resected and block endoscopically. And finally type 3, that is nearly avascular or has just loose vessels and amorphous surface that corresponds to 5N Kudo pit pattern, and is associated with deeply invasive carcinoma, that should be resected surgically. It was found that the diagnostic ability of type 2B is the weakest. And in one Japanese study, deep submucosal cancer was identified in more than 50% of type 2B lesions, which means inappropriate endoscopic resection instead of surgical resection. That led some to recommend using contrast agent to define the pit pattern before resection in that type. And if it is 5I, low-grade pit pattern, resect. And if 5I, high-grade, do not. Before leaving the magnifying endoscopy, I would like to answer that question: can we do magnifying image classification with non-magnifying endoscope? To answer that question, we need to know that the zoom endoscope has a magnification power from about 100 to 150 fold. And with the non-magnifying endoscope, we can reach about 60-fold magnification, by getting close to the epithelial surface up to 2 mm distance, which give us an optical magnification of about 40 folds. And in combination with the 1.5 times digital zoom, we can achieve about 60 folds magnification of the lesion, which is pretty enough. Therefore, The answer is yes. We can do those classifications by non-zoom HD colonoscopes. We finished with the magnifying endoscopy classifications. Now to the non-magnifying imaging classifications. The first one is the NICE classification. The NBI International Group developed the NBI International Colorectal Endoscopic Classification or NICE classification in 2009. It is similar to JNET classification but without magnification. It has 3 types corresponding to the 3 types of JNET but without clear subclassification of Type 2. Type 1 corresponds to JNET Type 1. Type 2 corresponds to combined JNET 2A and 2B, and therefore, it could include low-grade adenoma, high-grade adenoma or superficially invasive lesion. However, they added a note in Type 2 that the presence of high-grade adenoma or superficial submucosal carcinoma may be suggested by irregular vessel or surface pattern, and is often associated with atypical morphology, for example depressed area. That note practically differentiate Type 2 into Type 2A and Type 2B as in JNET classification. And finally Type 3, which corresponds to JNET Type 3. Here is the diagnostic performance of NICE classification, and as you see Type 2 is actually performing very well. But why is that? Why NICE Type 2 is performing better than JNET Type 2B? That is because unlike JNET Type 3B, it includes the low-grade adenoma lesions, which represents the majority and therefore, dominated the validation results. But still, NICE Type 2 is as problematic as or even more problematic than JNET Type 2B, and represent a therapeutic decision challenge. Now let us go to the WASP classification. As we have seen in all the previous classifications, there was no classification that can differentiate hyperplastic polyp, which is non-neoplastic, from sessile serrated polyp, which is precancerous. Therefore, the WASP group developed the WASP classification to identify sessile serrated adenoma. If the NICE Type 1 lesion is having 2 feature of the following 4, then the lesion is sessile serrated adenoma, otherwise it is a hyperplastic polyp. The 4 features are clouded surface, indistinct border, irregular shape, or dark spots inside the crypts. This is the relationship between different enhanced imaging classifications types, CUDO, SANO, JNET, NICE, WASP and Vienna classification. Now we finished talking about the enhanced imaging, now to roll the conventional white light endoscopes in the optical diagnosis of colorectal neoplasia. Actually, there is only one piece of information that we can look for in white light image, which is whether there are signs of deep invasion or not. First, the significance of the morphological type and relation to deep invasion. These are the average risk of deep invasion in various morphological types. And as you see, the most risky morphological types are Paris type IIC, LST pseudo-depressed type, nodular mixed with dominant nodule and the LST flat type. In one study, the accuracy of deep invasion in a depressed lesion is 91% if it showed these findings: 1. Expansion appearance of the tumor and or the surrounding area, like if there is a submucosal tumor; 2. Deep depression surface; 3. Irregular bottom of depression surface with protrusions; and 4. Folds converging toward the tumor. If you found any of these findings in a depressed lesion, you could refer him to surgery straight away. Finally, we have other signs, which can be identified by conventional white light, that are indicative of deep submucosal invasion. These signs are specific but not sensitive, therefore, if one of these findings is detected, then surgery could be considered. While absence of all of them does not exclude deep invasion, and you should rely on enhanced imaging before endoscopic excision. The first one is the non-lifting sign. The second is the converging mucosal folds towards the tumor. The third is the white spots or the chicken skin appearance, which represent a cholesterol deposition at the periphery of the cancer lesion. The fourth is the expansion sign, which is protrusion and overextension of the tumor and or surrounding normal mucosa, like a submucosal tumor. The fifth is the strong redness. The sixth is the tumor stiffness. The seventh is the bleeding ulceration. The eighth is the full or swollen stalk of pedunculated polyp. and finally ulceration and narrow or obstructed non-inflatable lumen that are indicative of advanced cancer. In conclusion, pathological classification of colorectal neoplasia should be according to treatment decision options. Real-time treatment decision of colorectal neoplastic lesion is based on optical diagnosis of its pathological type. Enhanced imaging is essential for optical diagnosis of the colorectal neoplastic lesion pathological type. Conventional imaging is only reliable when it suggests deep invasion. Thank you.